We're going to bring up our first speaker, and according to the list, as you come up, it is the validation of observational clinical human reliability assessments in laparoscopic colorectal surgery performed by specialists. And we're going to have that done from our group from the Imperial College of London in the UK. Please introduce yourself, sir.
Thank you, Dr. Rosen. My name is Danilo Miskovic. I'm from Imperial College in London. And I would like to talk about this complicated title, Validation of Observational Clinical Human Reliability Assessment in Laparoscopic Colorectal Surgery. We have nothing to disclose. The National Training Program in Laparoscopic Colorectal Surgery is a structured and formalized training program for specialist colorectal surgeons who wish to start laparoscopic practice. As you can see on the slide, there are several stages, and one of the main parts is supervised training in the middle here. The program is assessed at each stage and audited, and a very important step is the summative assessment at the end of the supervised training before they embark on independent practice. Currently, this summative assessment is carried out by the apprentices or candidates submitting to video-recorded resections, and they are then sent to two independent blinded assessors who watch these videos and score them on a scoring sheet that has specifically been designed for that. They then have to decide whether this is a pass or a fail case. If they do not agree, there will be a third assessor who makes the final decision. Although this system is quite practical and quite robust in a real-world environment, we wanted to explore new ways in assessing competency. So we wanted to check whether OCRA, this method, is construct and concurrent valid for competency assessment in laparoscopic colorectal surgery. Let me just talk very briefly about the background or the conceptual background of this method. Like any human reliability method, it's basically an analysis of errors and a classification of errors within a work process. So in this very simplified graph of a surgical work process, we're looking at different errors at different stages. We believe that the errors occurring at the interfaces between surgeon and instrument and targeted tissues are actually the ones that define performance. And both of these errors can lead to consequences, or they can remain without a consequence, so-called near misses. So we were analyzing 32 cases by trainees or apprentices, and also by experts from the National Training Program, and we were identifying these errors in order to have a measure for proficiency. We're also interested in efficiency, so we were measuring the time they spent on actual tissue dissection and the time they spent on just exposure of tissue. And we thought, or this was the hypothesis, that this is a surrogate for efficiency. So we had 32 cases, 10 by experts, 22 by apprentices. There was no difference in terms of case complexity. We found a total of 399 errors. Majority of them were tissue handling errors, and you can see most consequences occurred during these tissue handling errors. There was a clear difference, obviously, between experts and apprentices, and we were not further surprised by that. But I think the important thing that we found was that there was also a significant difference between those who failed the test and those who passed the test. So these are surgeons from a same or similar experience group who could be differentiated. And we could see this trend through different error types as well, although here we got in trouble with sample size. But we could see that tissue handling errors are actually the ones that most likely differentiate between good performers and underperformers. In terms of efficiency, we could see that the experts were more efficient than the apprentices, but there was no difference between those who passed and those who failed the test. When we tried to correlate that with the score they got in their assessment, in their summative assessment, we could see that there was a negative correlation between number of errors and the score they reached. So the lower they scored, the more errors they committed. And with that, we could then model cutoff scores using RC curves for both methods, and we can then quite accurately identify those that fall in this region where we think that they should pass the test, so we can increase the accuracy of the overall test. So in conclusion, ladies and gentlemen, we believe that the number of errors is a surrogate for the quality of surgical performance. We think that OCRA, especially in a combination with other observational assessment methods, can be used for competency assessment and also for other measures for surgical quality. Thank you very much for your attention.
Thank you very much. That was great.